So what is the principle of refractive surgery? It's that the corneal curvature is changed. In myopia, it is flattened. In hypermetropia, it is steepened. And in astigmatism, both are done. Now let's understand both of these conditions. First, let's start with myopia. This is the cornea and the eyeball is too lengthy. So what happens here? The light rays come and they converge too much and focus in front of the retina. Okay, that is the pathology of myopia. So what we are doing here is we are flattening the cornea. The cornea becomes a bit flatter like this. So the rays, they can converge onto the retina. That is, there is no premature convergence of the rays. I hope you are understanding what I am trying to say. The rays go a bit further with the help of some divergence because the cornea is flattened and it focuses on the retina. This is how refractive surgeries work in myopia. In hypermetropia, similarly, you steepen a flat cornea so that the image falls on the retina. What happens in hypermetropia? Usually that the image is focused behind the retina. If you steepen the cornea, what happens is it helps in converging the lights exactly on the retina. And in astigmatism, both of these procedures are done. Now, the most primitive type of refractive surgery that was done is radial keratotomy. It could correct up to 3 diopters spherical error of the eye. So the procedure was, see these, you can see these lines. These cuts were made in 90% depth of the cornea, so the cornea would get flattened. So mainly you can understand that it was used to correct myopia. See, what you can make out from here is you're cutting 90% of the depth of the cornea without measuring the requirement depending on the refractive error of the patient. So it results in unwanted hypermetropia, right? That is why it is not recommended now. There is excessive flattening of the cornea in this condition. So it results in unwanted hypermetropia. So this procedure is discarded now. Now after this was succeeded by our PRK, that is photorefractive keratectomy. That is, you are removing some part of the cornea. Keratectomy, you are removing some part of the corneal tissue. Using an Excimer laser to do this procedure. Okay, the wavelength over here is 193 nanometers. Please remember, this can be frequently asked, and it can correct up to -5 diopters of myopia. Okay, what you do is, you can see from this picture that the laser beam is focused onto the epithelium of the cornea and it is ablated. This cornea is removed and this results in correction of the refractive error up to -5 diopter sphere. However, the disadvantage of this is that it is very painful because we know that the epithelium is rich in nerve fibers. Epithelium has very high nerve fibers. So it is a very painful condition that can last for a very long time after the surgery. Also, if you damage the Bowman's membrane, we know that it does not regenerate, so it can result in corneal scarring. These are the 2 drawbacks of this procedure. So now the latest procedure is our LASIK. We all are familiar with this word. So LASIK is laser assisted in situ keratomiliosis. Kindly try to memorize this full form. Okay, it is laser assisted in situ keratomiliosis. The word keratomiliosis means change in the corneal shape. Change in shape of cornea. Okay, it is a gold standard procedure and it can correct myopia up to -10 diopters. It's an average. Sometimes it can correct up to -12 diopters also. Hypermetropia up to +5 diopters and astigmatism plus or minus 3.5 diopters. So 10, 5 and 3.5. Okay. Here also the most complicated and sophisticated Excimer laser is used. Now let's look at this procedure. What is done over here is that the keratome cuts the cornea below the Bowman's membrane. So here you are eliminating the issue of pain as well as scarring. You go beneath the Bowman's membrane and you can see in this picture that a flap is created. This flap over here, it is lifted but it is attached to the cornea on one side and it is lifted from the other side. The flap containing epithelium and Bowman's membrane is removed. So the next layer, that's nothing but your stroma is exposed. Okay, once the flap is reflected back, and this Excimer laser is used to ablate the cornea. Once the ablation of the corneal stroma is finished, see the flap is placed back into its position and it heals back naturally. So we have seen that it is eliminating the pain and corneal scarring. Okay, is this procedure clear? First you create a flap and you ablate the stroma. The stromal thickness, how much it should be ablated, is decided based upon the refractive error of the patient, based on number 1 the refractive error and number 2 the corneal thickness. Okay, corneal thickness. These two decide how much of the stroma you're going to ablate. Okay, then again the flap is placed back in its anatomical position. Now that we have spoken about corneal thickness, we have to mention about this procedure called pachymetry, which lets us allows us to measure the corneal thickness. Pachy means thickness, so we measure the corneal thickness with this pachymetry. It is the single most important factor which decides how much you are going to ablate in the LASIK. So there is a stipulated amount of thickness that is required so that you can call a patient eligible for LASIK surgery. However, an absolute contraindication for LASIK surgery is keratoconus. Please remember this, it can be asked. An absolute contraindication, straight away you reject it.